So good morning, everybody. So I'm presenting the output from the respiratory working group. We're a little bit behind cardiac and bone and endocrine, but we have now got agreed our final guidance, which has been out to consultation a couple of times, but we haven't quite got to the same point as the other two groups. And I've just listed the people who've contributed to the respiratory working group there. Some of whom are here, which is great. Chris, who is sitting on that table there, is going to add comments when I get it wrong from a respiratory point of view. And Philippa is joining us to talk a little bit more about the patient perspective. I think that's also wanted to highlight the contributions from Marinella, from Alex and Kathy, and say that, like the other guidelines, we've based what we've produced on both the British Thoracic Society guideline for respiratory management of children with neuromuscular weakness. I can't remember when that was published. There you go. And obviously the international standards of care, and also taken on board what was written in the adult standards in Roz's publication. So just to look, you've seen, can we close those off the screen? You've seen this sort of documentation. This comes from the survey that was done by Duchenne UK with patients and families. And I just wanted to highlight the fact that actually in the scheme of things, looking across the spectrum of different elements of care, respiratory was perhaps one of the better ones, in that only 23% of the respondents, that's 37 of the 164, felt they actually had poor or very poor care. But like most areas, only so less than half the people felt they had good care, and that did vary very much depending on what age you looked at. But overall, reassuringly, 81% of patients did receive some kind, or perceived they received some kind of respiratory care, and about 50% were satisfied with that. 78% saw a respiratory specialist at least once a year, which I think is pretty good as a baseline. But then on the other hand, 40% nearly of the people haven't had their spirometry testing done. And we'll come into that a little bit, that there may be some reasons for that. And just to look about some of the comments that were made, I think parents had stressed, and Philippa can probably speak about this a bit more detail, the importance of clearly explaining what we were doing and what the tests were for and what they meant, what the results meant. The importance of doing appropriate tests in different cohorts of patients, and making sure that the people doing those tests knew how to do them, and that people were able to access effective management and care. And the importance and the role of an individualised care plan came out quite a lot. And I think one of the things that Philippa is going to talk about a little bit is this concern about variable access to care in different places. So I'll let Philippa chip in there.
Okay. Thank you. I'm sorry, I haven't got any slides. I'm not being organised with some personal issues, so you have to listen to my boring voice. Hopefully. So my background, for those of you that don't know me, many of you do, is that I had a son, Dan, with Duchenne muscular dystrophy, who I lost at age 27 in 2019. So I've gone through the whole diagnostic odyssey, the whole journey with Duchenne. I've been working with these guys ever since as a legacy to Dan, to try and make sure that we don't go backwards on the care plan going forward. Respiratory, as many of you know, is a massive part of the Duchenne journey for our families. And that starts right down in paediatrics, when they're first monitored with the peak flows tests, and then goes right through to adult. And I think one of the issues for the families in paediatrics, that although the care is really, really good, is, as Anne-Marie was alluding to, is the actual type of tests. So I'll be guided going forward, and we will in the guidelines, by the consultants and the respiratory guys that know what they're talking about. But peak flow tests for us with Dan with learning difficulties was a real issue, because we never ever got accurate results. So it's looking going forward as to how we can improve that for that cohort of patients, and perhaps explaining to the children so that they're not frightened. And I know that that's something that Alex and Emily will be looking at going forward in these guidelines, and it's stuff that's covered in their handbooks that they give to patients. Going through into adult services, you tend to fall off a cliff, as we all know, not just in respiratory but in the other places. And one of the deep conversations that I've heard from families is that in the community and the local services, adult respiratory physicians don't know anything about Duchenne. And one complete comment was, oh, well, if you come to me with a chest infection with your Duchenne as an adult, I'll just put you in ambulance on blue lights to your specialist centre because I haven't got a clue. So that's not very reassuring. So I think going forward in these guidelines, we need to make sure there's the education for local community respiratory teams, the specialist centres link in with them. There is no divaship when families go into A&E in an emergency, whether it's just a basic chest infection. If they're worried, they've got equipment, and the A&E doctors just look at them and say, well, you know what you're talking about, but we don't know, and they won't ring your specialist centre. So it's that communication. And now, again, that's not just in respiratory, that goes across the board in other areas. Access to prescriptions prophylactically for chest infections in paediatrics can be an issue. Some GPs are very loath to actually issue them for parents to hold on to, and then go and get made up when the children are starting at that early stage, which would be such a godsend and would make sure that they don't get really ill. With my journey over the years in Duchenne and the whole diagnostic journey changing, I think the fact of access to equipment when the boys are older, cough assist machines, and the access to those, I don't want to see us going backwards. Those in the room like Francesco and Volker will be aware of the work that Mike Hanna and we did with MD UK a long time ago about the discrepancy in life expectancy between the Northeast being really on the ball and the people in the Southwest, and the 10-year life expectancy difference for those Duchenne boys because they couldn't access equipment. And I know we seem to be hitting with the problems with the NHS areas where you cannot access this equipment. We cannot and we will not. I know Emily and Alex won't let that happen. We can't go backwards. We need to drive forward. We need to get in on these ICSs, and we had this conversation with Ros yesterday, and it's about the commissioning. So there's a lot of work to do, but I know it won't go backwards going forwards. And I think families just need that peace of mind that, as we were talking about, inequity of service around the country, and a lot of the forum questions are that they can get the access in some areas, they can't in others. So we need to push forward, make sure these guidelines are in place, we educate, we get the information out, we involve people on all standards, and even down to things like, for me, I would say paramedics are a vital group of people we need to educate. I can remember being in an ambulance with a guy that I was actually a friend with as a paramedic. He came to me and said, please, can you come and talk to the paramedics locally so that we know what to do in an emergency situation. But I think in the great scheme of things, as Anne-Marie said earlier, the respiratory response and the fact that families are getting fairly regular appointments, patchy though it may be and sometimes, is a positive, but there's still lots of work to do.
So I just wanted to give a quick sort of summary about the natural history of respiratory weakness in Duchenne, because this obviously informs the guidance that we came up with. So these are some graphs from the McDonald paper that's come from the Synergy database, which looks at what happens to the forced vital capacity, which is a measure we use a lot to sort of estimate, I guess, lung capacity and function across a number of conditions, but in particular in Duchenne. And you can see that the levels increase and then gradually decrease, probably around 12. And you can see here there's a bit of variability with or without steroids, but that's really not what I wanted to show, but just looking at what happens to the predicted values. So there is a fairly predictable and well understood course that occurs. I think one of the things that is also interesting and work that's been done is that we can mirror that with what's happening to the upper limb function. And that's probably very important for some of our boys, like Dan, who struggle with formal lung function testing, because these other markers can help us predict when these older lads are more vulnerable to developing respiratory decline. So this is the Brooks score, which is quite simple. I'll get a physio to demonstrate it shortly. But it's something you can do quite easily in clinic. Even a not very well-trained neuromuscular doctor might be able to do it. And also there are other factors like scoliosis, which are going to make more boys much more vulnerable to decline, as is cardiomyopathy, as is poor bulbar function, as is poor nutrition. So it's needing to sort of think about these things in the round. But we also know that fortunately it's very unusual to have significant respiratory impairment before loss of ambulation, because unlike perhaps the cardiac disease, it does mirror what's happening with the rest of the muscle function. So just to sort of summarize the general principles that the guidance sort of focused on, was that we talked about monitoring. but highlighted that although it's really important, it can be quite difficult for a number of reasons. Pulmonary function testing can often be challenging in certain groups of patients. And the other big challenge is actually deriving these percentage values, which tend to be used for cutoffs for different interventions or different strategies, because measuring height in somebody with DMD is challenging, both in the ambulant and the non-ambulant population. But the importance, and what we've highlighted in the guidance, is that whatever you use, whichever system you use, keep using that, so that you have got relative information for that individual person as they move through your clinic, and you can highlight when things begin to change. History is important, and I guess there are two key elements. There's issues around infection and secretion clearance, and then there's issues around sleep disordered breathing. And one of the things that was very important and we wanted to highlight was this concept of sleep disordered breathing rather than hyperventilation or nocturnal hyperventilation, because we know that there are young people who also have obstructive sleep apnea, and we're giving these young people steroids. We're often changing their morphology. We're making them more vulnerable to having these other problems, and they can also impact quality of sleep. It's been highlighted, unsurprisingly, that having access to specialist physio is important. Physios who understand how to use techniques to help clear secretion, particularly in an acute setting. And also highlighted the importance of onward referral and having a low threshold for patients to send them to a specialist centre. And obviously these systems are very service specific. So how it works in different parts of the country is very different, and it's different for children and adults. So with children, a lot of their monitoring and oversight is happening within their neuromuscular clinic. When you move into the adult services, your service is more fragmented. And some centres have kind of those coordinated in one site. We've heard about Rosa's service, but we have a 3-in-1 clinic in Leeds where you can see a respiratory physician, a cardiologist, and a neuromuscular specialist. So different systems for different centres. So in terms of routine monitoring, when should it be done? Well, we think it should be done as soon as it's practical. Even though we know that the values might not be very helpful, there is something to be said for getting the boys used to doing the process early, used to trying the spirometry. The physios are very skilled, but you need to have someone who knows what they're doing and has done it with a person with Duchenne, who knows to know what interface, when to stop pushing them, when they're tired, when it's not going to be a meaningful result. And it needs to be an appropriate interface, and that might be a mask rather than a mouthpiece. How often should it be done? Well, the recommendations are every 6 months in the international standards of care, but we thought it was more practical to say 6 to 12 months in our ambulant patients, but at least every 6 months in the non-ambulant patients, but more often if somebody's having symptoms. So we have to be responsive as well. What monitoring do we do? Well, we need to make sure we do take accurate history. As I've said, we've said in terms of the minimum that the function testing should be an FVC and a peak cough flow. There are lots of different techniques people use in specialist centres, but in terms of what we would advise for routine monitoring, this is what we're saying. And once you get referred to your specialist centre, they may engage other techniques and more detailed testing. Sleep studies, we spent a lot of time discussing, and I think suffice to say the consensus was that they should be guided by the specialist services. Chris is looking at me, he's going to say something, because
I think she's asking me to interrupt.
Yes.
So as with everything in medicine, there's lots and lots of different ways of doing things. Sleep studies is a generic term for lots of different things that can be done to monitor your sleep at night. The most basic that we do is something called an oximetry, which measures your oxygen and your heart rate at night. And then you can get progressively more and more complicated sleep studies, the information from which becomes less and less useful the more complicated they become. The ultimate end being something called a polysomnography, which if you're in Europe would be, or America, that might be what you do. But that tells you a lot of detail about your sleep stages, which isn't necessary to determine whether or not somebody needs ventilation. And what we're looking to do is to do something that's pragmatic, that can give us signs about whether or not we need to advance towards doing more detailed studies or towards deciding whether or not we initiate ventilation. And overnight oximetry is currently considered a reasonable screening test to look for either obstructive sleep apnea or hypoventilation. And when you go back to Anne-Marie's graph, you can see that FVC kind of matches nicely to about teenage life. So you don't necessarily need to do too much investigations in someone who's asymptomatic early on in life, but you might want to consider different things as you go on. I think we suggested that as you go on further in the guidelines with blood gases.
Yeah. I think we did discuss whether doing spot testing in clinics was helpful, and the consensus was that in children a spot oxygen level or a spot CO2 in your clinic wasn't particularly useful. Different adult centres use them in different ways for people who are already established on ventilation, and that's a slightly different question. So we talked about the testing that should be done and agreed that everyone should have an FVC, and that we should document both the absolute and the percentage values. I've talked to you about that already. The ideal equipment for doing your POF peak flow, which I've put down the wrong way around, sorry, is a pneumotachograph, but many centres don't have that. So doing a peak expiratory flow using a mask rather than interface is a reasonable compromise. We've stated that. And again, capturing in the cough peak flow both the absolute and the percentage values is again important, because what you're looking for is change. Change that you think is consistent and representative, not just I've got a chest infection today. We also looked at vaccination and essentially recommended that vaccination was done in line with the recommendations in the Green Book, which specifies about annual flu vaccination and when pneumococcus should be renewed after the sort of early infant programme. We also have made some comments about COVID vaccination. We talked a lot about, using this term sleep disordered breathing, and I think I'm now indoctrinated and I'm using it regularly. Just again defining that there's two different elements to that, and we've talked about that in the guidance. We've defined what the typical symptoms of that might be, but also highlighted some of the atypical presentations that should perhaps guide you to thinking about that, and the challenges of doing that in those young people who've got cognitive and behavioural issues, and the fact that if you have a clinical suspicion, then you need to refer to a specialist service early. We've defined what that specialist service should have, and we've included the fact that there must be access to specialist physiotherapy as part of a service that calls itself a specialist respiratory service. But we've avoided quite specific guidance about what those centres do, because it's too difficult to get a consensus across that's going to be meaningful across the country. We have outlined some specific criteria for onward referral, and certainly symptoms, irrespective of what your monitoring shows, should trigger a referral. So should symptomatic reduced cough strength, and certain groups you should think about referring earlier, as I've said, those who can't do lung function testing, those with significant scoliosis, using the Brooks score as a guide perhaps for people, which I'm not sure that has come into practice as much, and certainly people who've got persistent symptoms that you don't seem to be able to get on top of. We've looked at thresholds. This is a difficult one. There are specific thresholds set out in the international standards of care, but there's a lot of debate about what they should mean. And we ended up with Michaela's diplomacy coming up with a compromise statement. So with respect to peak cough flow, we've really only set out a level in adults that should trigger referral, because it's too difficult in children. We've picked the same FVC points that are used in the international recommendations, but rather than say that should mandate somebody having a specific intervention, we've said that highlights that this individual is vulnerable. So there is evidence that around 50% of your FVC, you may be vulnerable to sleep disordered breathing and might start to be at a level where you might need that ventilatory support. So you should definitely be under a specialist centre by then. If your FVC's gone under 30%, then you're at much higher risk, and therefore that referral should be urgent. There was a discussion about the timeframes for referral into adult respiratory services, and the fact that therefore it was important to be able to kind of have a red flag that would allow someone to get access quicker. We also felt and have highlighted the fact that despite the fact that you've been seen once, you shouldn't be discharged, because that change is inevitable, a bit like what John was saying with the cardiac surveillance. Just because you've had one normal assessment doesn't mean you should be discharged and have to go through the process again. So it's encouraging centres to keep people on their books. Again, you know, we've had to be careful. So respiratory impairment is, am I about out of time?
2 minutes.
To anything, or for talking?
2 minutes for talking.
Okay. Sorry, would be tailored, I think I'm nearly there, to individual patients' needs. We talked about having a low threshold for antibiotics and specifying an FBC that might make you think about that. And we've got guidance about emergency care and cough augmentation. Highlighted the fact that in terms of emergency care is an area that's quite a concern for, I think, both clinicians and families, that highlighting that those with DMD can deteriorate rapidly, even though they've been quite well before, and that they may not show the expected signs of distress when they pitch up. This is quite busy, but I think that again it links in very much with what the work being done with the emergency care group. That we've stressed it's very important that if someone ends up in their local hospital, that they make contact with a specialist centre to get advice early, and a physiotherapist needs to be involved in seeing the child. That these patients may well need acute ventilatory support, but that needs to be delivered in a centre that's got specialist expertise and monitoring, and that non-invasive ventilation should be the first consideration. There's been a lot about excessive oxygen. I have to say it's a slight bugbear of mine, but we have put quite specific guidance about saturation levels that you should be aiming for in both adults and children, and highlighted the importance of the fact that that can worsen hypocapnia, and the fact that if somebody is struggling with DMD to maintain their oxygen, what they need isn't more oxygen, what they need is ventilatory support. There's a comment about acute tracheostomy that shouldn't be done without advice from a specialist centre, and the fact that it doesn't help weaning, it doesn't get you out of the ITU quicker. And just kind of talked, also thinking about, you know, the patient voice and the critical elements about advanced care planning, and how respiratory care is going to interface with the palliative care, and thinking about care planning and how that works. There are obviously other things to think about, like the issue around adrenal suppression, like the possibility of cardiac disease. And we've also highlighted fat embolism as a condition that could present with a respiratory presentation, but has a bigger picture. Now, this is what we've ended up with. I'm not expecting you to read this, but Kathy has magically got all this guidance onto 2 pages. So, you know, and these hopefully should be available soon. In terms of the next step, the British Thoracic Society have endorsed the guidelines, which is very positive. The patient parent-friendly leaflets are nearly ready. The manuscript's being prepared for publication, and we'd like to get that submitted and accepted before we send the guidelines out for more wider, disseminate them more widely. We've thought about who needs to have them, because it's not you sitting in the room, and how we're going to get to the people who need them, like emergency departments and general peds or acute medical assessment units. And we've thought about how we're going to link with the other work streams. And obviously there's quite a lot that interface with respiratory, and I promise I'll shut up now.